Hello, everyone. Thank you so much for joining Evoke Neuroscience today for a Lunch and Learn webinar. My name is Dr. Morgan Ingmanson. I'm the Director of Medical Affairs here at Evoke. And we are so excited to have Dr. Kelly Ryder with us this morning as a guest speaker to talk about TBI case studies. But before we want to dive in, I want to make sure that everybody can hear me loud and clear and that you can see my screen. So in your GoToWebinar menu, I want you to go to the question section, type in there, let me know what you did over the weekend. I am located in Sacramento. It felt like summer here, so I went kayaking on the American River in the middle of February. It was fabulous. Wonderful. So people can hear me, you can see my screen, and now you know where your question box is. That's going to come in handy as we work our way through this webinar. When Dr. Ryder is presenting, you might have some questions that pop up in your head. I want you to go to your question box and type those in. If I know the answer, I can type back and answer it immediately, or we can ask these questions to Dr. Ryder himself at the end of the webinar. So use your question box, keep it handy. So diving right in to our day on TBI, we're going to be talking about EVOX applications for TBI and walking through some real-life case studies. So I want you to be able to first off describe the electrophysiology biomarkers that are useful in helping diagnose TBI. We've got to understand these biomarkers before we can really take the next step and learn how they apply to our clinical utility in helping diagnose and monitor patients after TBI. I want you to understand the clinical value of QEEG for concussion cases, and then also describe how EVOX can be used to monitor recovery. TBI is one of those things where sometimes it doesn't take that much to diagnose it if you are aware of a very serious head injury that occurred, but we want to be able to track the patient's progress after they've recovered to make sure they've recovered fully before they go back into any type of athletic situation or military situation, et cetera. And finally, I want you to be able to integrate EVOX into your clinical workflow for patients that do have a history of head injury. So Dr. Ryder today is going to be describing how he uses EVOX in his practice, and hopefully you'll be able to pull from that and apply it to your own practice. So starting off with just a bit of background, diagnosing and monitoring TBI recovery is very important. 3.8 million people every year in the United States experience a concussion, and symptoms can be really broad. We're talking mood and affect, attention, arousal, language, memory. So sometimes it is difficult to pinpoint what is causing these symptoms. A key problem in diagnosing and monitoring recovery is that the standard tests really aren't directly measuring brain function. Sometimes these tests are susceptible to patient motivation. This can really come into play for our athletes. Maybe they're not giving their best effort for a baseline assessment. So when they do experience a head injury, they're able to match that initial baseline performance. And if we are trying to look at the brain directly and we're doing that with structural neuroimaging, we're really failing to identify functional injuries. And that's what's gone wrong in a TBI. It's the way the brain is functioning is impaired. So I want to walk through this baseline of recovery after some type of a head injury. We've got baseline health and a very acute injury occurrence. We drop down our functional status to what is symptomatic. That's when we've got these problems with memory, language, attention, arousal. And gradually, these symptoms are going to spontaneously go away, right? Symptom resolution. Then we're going to feel asymptomatic, like we are back to our baseline health. What is actually happening in the brain is a much slower recovery process, which is called injury resolution. So notice there's a period of false recovery going on here where the patient is asymptomatic, they think they're okay, but the brain is still working on that injury resolution. So our challenge is to get the detection ability for when true recovery has occurred. And then we know that the brain has recovered, symptoms have resolved, and that patient is now in their healthy baseline state once again. So a couple biomarkers I want to review just to orient you to what Dr. Ryder is going to talk about. 3 key biomarkers associated with TBI. The first is heart rate variability, specifically reduced heart rate variability. We're going to be talking about ERPs, P300A and P300B. as well as resting state, QEEG, knowing how to recognize signs of a TBI and even neuroinflammation after a head injury. Now, I'm going to breeze through these next couple slides. If you have not had the opportunity to review our TBI webinar that specifically talks about biomarkers related to TBI, that is already created, it's already available to you. So if you need access to that webinar, shoot me an email, medicalaffairs@evokeneuroscience.com. I'm happy to give you that resource. So no, I'm going to go through these slides quickly. They should be a refresher, a reminder, and if you want to go to that original source, it's there for you. So starting off with heart rate variability, why are we looking at the heart at all? It's because the heart and the brain are really related, and they give us insight into the autonomic nervous system. So are we in sympathetic mode or parasympathetic mode, or are we able to easily fluctuate between the two? There's really two ways to look at HRV. The first is the time domain. This is the easiest domain. It's just how much variability is there in heart beat-to-beat intervals. Now, typically we want the heart to beat sporadically as opposed to like a metronome. Sporadic heart rate variability means the heart is responding in real time to what the body needs. So we want to see this very high variability in beat-to-beat intervals. Now, a study looking at concussed patients versus controls found that heart rate variability was reduced in the concussed patients. That means the heart was beating more like a metronome. They were not very resilient anymore. They were really in recovery mode. The body was certainly stressed after that injury. So we know that reduced HRV as measured by SDNN, which is that time domain standard deviation of end-to-end intervals, is a biomarker of TBI. Now we can also look at HRV in regards to the frequency domain, which basically asks how much power does each underlying rhythm have within this heart rate variability. So we can break down HRV into really three different frequency bins. Very low frequency relates to sympathetic dominance, low frequency is balance, and high frequency is parasympathetic. So we'd like to see the most power in the low frequency zone, meaning the patient can easily shift between sympathetic and parasympathetic functions. But what we see most often in our concussed patients is a shift toward the sympathetic side of the scale. So sympathetic to parasympathetic power ratio, these concussed patients are shifted all the way over to sympathetic dominance, meaning their system is really stressed. So sympathetic dominance is a biomarker of TBI. Moving on to our event-related potentials, we know that ERPs reflect brain processing speed. It's our time-locked neural activity. And the way it works is we've got a raw EEG signal. We're showing a patient different types of stimuli and then looking at a window in time after that stimuli was shown. We're going to average all these windows together to create one big, beautiful ERP time-locked EEG segment. From this EEG segment, we can pull out a couple different metrics. The first is P300A, which really reflects attentional capacity. It's an orienting response. So when something changes in your environment, can you attend to it? And we can also look at P300B, which is working memory and information processing. This is reflecting sustained attention and really the ability of the brain to combine different resources to accomplish an action. So how can we interpret these ERPs? There's really twofold. The first is latency, which is reflected on the x-axis, and it's just milliseconds. How much time did it take the brain to mentally classify a stimulus? And we can also look at amplitude, which is on the y-axis. This reflects how many neurons are successfully working together to process that information. I always like to think of amplitude as neuronal horsepower. You want a lot of horsepower behind that information processing. So when it comes to how ERPs and TBI relate to one another, we're looking at controls versus TBI, orange for the controls, blue for the TBI. And for P300A and P300B, there's a significant delay in latency for the TBI group. So the brain is just slow to orient to new information, and it's slow for that working memory to process that information. Likewise, we see a reduced amplitude for our TBI group in P300A and P300B. So not only is the brain slow to process information, it doesn't have very much horsepower behind that processing. And this is especially pronounced for P300B. P300B has been most studied when it comes to TBI, really affects that working memory, information processing. And we can see that in our control subjects, the very top line, nice healthy amplitude here. Our asymptomatic subjects have recovered a little bit, but they're still not equivalent to our controls. And then our symptomatic subjects with active ongoing symptoms of TBI have a severely depressed amplitude. So we can conclude that P300, A and B, but really paying special attention to P300B, we're looking for reduced amplitude and a delayed latency as biomarkers of TBI. Our last biomarker we want to pay attention to is our computational EEG. Remember, this is a comparison of your patient's brain compared to our normative database. The way we map this out is through a power scale, color rainbow, where blue indicates a deficit of a certain brainwave frequency and red indicates an excess. Remember, these colors just reflect Z-scores. How many standard deviations away from normal is your patient from our normalized database? We're going to map it onto these heads you see. Remember, this is an aerial view, top down. We've got the nose in the front, left ear on the left side, right ear on the right side. And we're going to map these colors in different areas of the brain. When you're interpreting these head maps, we're always asking three questions. The first is, what frequency do I see an abnormality in? Remember, slow frequencies kind of range from 2 to 10 hertz. Fast frequencies range from 10 to 30. Breaking down that delta, theta, alpha, and beta frequency bands. The reason why we care what frequency an abnormality in is because frequencies relate to physiological states and also pathology. So question one is what frequency, then we move on to what power do we see? Do we have an excess or a deficit? We would like to see green in every single frequency. That's probably not what you're going to find. So then we have to ask, do we have not enough or too much of that certain frequency? And finally, we're going to ask, what brain region are we looking at? This oftentimes gives us insight to symptoms the patient is experiencing. And in the case of TBI, you can actually see the coup-contra coup happening that really reveals where the injury occurred in the brain. So talking about QEEG and TBI, I love this quote from Thatcher. QEEG is a reliable, objective, clinically sensitive, and inexpensive method to evaluate the effects of a rapid acceleration-deceleration injuries to the brain. Basically, QEEG is a wonderful tool for TBI. Now, there are a couple different changes we can observe for our TBI patients compared to our controls. On the left hand of your screen, you'll see that the patients in the black line appear to have an excess power for our slow frequencies and then a deficit of power in around the alpha frequency band. And indeed, there can be a lot of different findings here for the TBI group. As a general rule of thumb, sometimes you'll see high power in delta and theta and then low power in alpha. So I'm going to walk you through a couple different types of patterns you can recognize that all do relate to TBI. So some TBI examples. Ideally, we would like to see green in all brainwave frequencies. This is optimal, probably not going to happen for somebody that's just experienced a head injury. So in our slow frequencies, you're going to look for low or high power with a focal point, and that's the key here. So this is an example of excess power in our slow frequencies with a focal point. And this is another example of deficit power, same frequency band with a focal point. So excess or deficit power with a focal point in this frequency band can mean TBI. And we can also keep an eye out for neuroinflammation as a result of this brain injury. Remember that TBI is a physical brain injury. It's an acceleration, deceleration, forces on the brain. It's really not happy, and there's probably some neuroinflammation going on, especially if you're getting this in the acute phase. The way neuroinflammation typically displays on these head maps is with high power in the beta band and oftentimes again with a focal point. So this is an example of that excess power focal point starting at 19 hertz, carrying all the way through about 24 hertz within our beta band. So to quickly summarize the biomarkers that we find most pertinent for our patients with TBI. The first is HRV, time and frequency domains. You're looking for reduced SDNN and or sympathetic dominance. For our event-related potentials, you are looking at P300, A or B, delayed latency and or reduced amplitude. And for our QEEG resting state head maps, we're looking for high or low power in the slow frequencies with that focal point. And we're also keeping an eye out for neuroinflammation, which is going to register as excess power in fast frequencies, oftentimes with a focal point. So that wraps up our quick review of TBI biomarkers. Again, if that was overwhelming and the first time you've seen those TBI biomarkers, we've got a webinar that walks through them much more in detail. So you have access to that if you want it. And at this point, I'm going to introduce Dr. Kelly Ryder, who is a certified sports chiropractic physician and director of sports medicine and rehabilitation for the Ryder Clinic. He was named as one of the top 37 concussion experts in the United States, and he's been an expert witness for many concussion cases. And he got his degree from Parker University in Texas and did postdoctoral studies in Iowa, all in sports medicine programs. He's got a very detailed background in sports medicine, was an athlete growing up himself, and has got some great ties to the NFL and the military. So at this point, Dr. Ryder, I'm going to hand it off to you. Thank you for being with us today. We're very eager to hear how you can use EVOX for your patients and some case studies that you're going to review.
So yeah, we're going to talk about QEEG and mapping of TBIs and concussions, and how can we objectively find out if the brain is functioning better pre and post therapy. So working with the majority of my clientele is NFL and military, we need to be able to objectify whether or not the individual is ready to go back to either the field of play or combat. And so we'll move to the next slide. So yeah, I do not have any financial interests or arrangements or affiliations with any organization that could be perceived as real or apparent conflicts of interest to the presentation I'm publishing this topic. So what you were seeing was my guys. The reason that we put that picture in there with the guys with the lights is because those guys are small groups, and every single one of them's brain needs to be working at 100%, because if not, somebody shoots one another, and that's not a good thing in my world. So we have to make sure that all 10 or 12 men are working at 100% at their best. So let's get to the next one. So I always tell people diagnosing a concussion does not define treatment or recovery. So oftentimes I see many individuals walk into my office that have been seen by multiple practitioners, from neurologists to neuropsychologists to general practice to pediatricians. And they tell them, yeah, you have a concussion, and then they walk out the door. But what I always kind of talk about is it's like a doctor saying, hey, you have a tumor, but we don't know if it's malignant or benign, and good luck with that. So I think that we need to do better and be better at defining what is actually going on with these individuals. And we'll get to the next slide. So what we do in my office is we take a comprehensive patient management approach. And the simple fact is that we have to have a pathological diagnosis, we have to have an impairment diagnosis, and we have to know functional limitations. So pathological diagnosis is that we're checking cranial nerves, we're seeing how each one of those are working or not working. Then we take an impairment diagnosis by using objective viable means of balance and vision testing with V&G goggles, and then we check their functional limitations with how their brain's actually working. And then we develop an evidence-based care plan. So we need to know in the world of military, do we send them to rehabilitation, or do we send them to surgical or pharmacological interventions, and then reassess these individuals? So we have to have a solid evidence-based care plan for these individuals. Let's go to the next slide. So the way we look at it is that we understand that how the brain's actually functioning is through balance control. So it has to be able to, you have to have balance working first before you start adding in all these other modalities, like somatosensory visual and vestibular therapy, sensory integration, movement strategies, perception of virtuality, visual and postural, and cognitive processing. So we always, in my office, always check to make sure that their balance is always working first. Then we go, because it's called the vestibulo-ocular reflex, meaning balance vision reflex. So that is how we kind of monitor these individuals. Let's go to the next slide. So we're looking at, in the process of using EVOX, is that we're looking at alpha, beta, theta, and delta. And what we do now with the NFL and some of these military individuals is that we're looking at delta wave activities, knowing that that's kind of our focal point. We found a hole kind of in the system is knowing whether or not these individuals are getting restful stages of sleep and how their brain's actually doing. So we kind of focus on the delta wave and monitor those alpha, beta, and theta waves, but mainly we're looking at delta wave activities. So let's go to the next one. So this is why I use QEEG. This is a 7-year-old little boy where he fell off the trampoline. I think it was 4 times at this time, and he was referred in to me from West Texas. Very high functioning kid. Very good grades, was 2 grades up in elementary school. Mom and dad got referred to me. His dad's brother was a B-52 pilot, and they called in and said, hey, this is what's going on. I said, I know where you got the reference from or the referral from, and here we are. So what you were seeing was this kid's brain was just in the tank, and after therapy and sessions, we were able to get him back up to normal. The kid was, as you could see, there was no signs and symptoms were there. On the left-hand side, you could see that he was suffering from headaches, nausea, vomiting, balance problems. This kid could not stand up at all. Fatigue, trouble falling asleep. We actually had to stop the exam multiple times due to this kid having multiple signs and symptoms of post-concussion syndrome at, basically 7.5 years old. So let's get to the next slide. So this is why we use EEG with eyes open, eyes closed. We're looking at superior colliculus involvement, meaning the eye tracking vision issues versus non. So you take the superior colliculus out. Delta wave is important to track to find out if the individual is resting, sleep, and or recovering. Let's get to the next one. So in this kid's case, clearly see that the brain is starting to recover from the first scan to the second scan, in the sense that is, we're getting more green with the eyes open and the eyes closed on both sides. So we're definitely making progress with this individual. We're tracking those markers also. We talk about what we're testing and why we're testing in Broca's areas and what we're trying to correlate with treatment and a care plan. And the reason that this map is kind of important as individuals that use EEG in our office is that we're trying to display to the jury in most of these individuals' cases that what is going on and how their brain's working. So that way they can actually have a map to understand. I like giving this map to patients, family members or their parents or people that bring these individuals in. So that way they can kind of understand and kind of get a map of an idea about what's actually going on with their individuals' brains at the time. Let's go to the next slide. So we use a targeted approach in our center. We can take these maps and actually get into using laser therapy or photobiomodulation therapy to actually stimulate these Broca's areas with these certain frequencies, and actually are getting substantial relief with these individuals in the way that they're showing massive improvements immediately, because what we're causing is a decrease in inflammation and an increase in activation based upon those brain waves and frequencies. And what I like this report to show me is like I tell the parents or the individuals, it gives me a roadmap to your brain. There's no one TBI or concussion that is the same. And I think that's where most sports medicine professionals and individuals get in trouble, is that they try to shove everybody into a box. And these cases are not boxes. These cases are very individualized. And so we use a laser to go in there and actually stimulate those certain frequencies of the brain in those sites. And if it's a high power, we tend to turn the laser down to 25 to 50% function. If it's a low area, we'll go 50% or higher based upon the individual's feel or comfortable approach to it. So we take a really targeted approach to care. Let's get to the next slide. So I always tell people the biggest thing that we're dealing with chronic stress, and the reason that we look at this is that in our military individuals and even NFL, we have chronic stress in these individuals because they're trying to get back to their job, right? So we have to look at hippocampus and the amygdala areas of the brain, and actually how do we control cortisol production in the body. And so this is just a little funny. I like to poke fun sometimes. Cognitive dissonance is why people get upset when they learn their beliefs are challenged, right? So just a little funny, nothing, just to make you smile. Let's get to the next slide. So we were, 10 years ago, well, actually 12 years ago, we started looking at some things, and people started kind of poking fun and asking questions whenever I was doing these talks nationally and internationally about the genomic link between the blast exposures, brain injury, and Alzheimer's disease. And I said, yeah, there was actually proof that that's happening in the sense that I'm telling you that people are having anxiety and they're having gut issues. And first things we have to look at is really looking at how the body's absorbing these B vitamins and how we have to address an individual's gut and their epigenetics and their polymorphisms to help their brain actually heal. Well, then there comes out a study that says, oh yeah, you know what, that's actually right. And here are the facts. There's a small school called UCLA you might have heard of that came out and actually published this, and it talks about decreased frontal lobe activity and increased brain activity in the thalamus, indicating sensory overload resulting in unusual perceptions. And this is where we're talking about the schizophrenic bipolar type stuff, where these individuals start to see things and they're hallucinating and they're not getting enough sleep and having insomnia and all these things. So we started looking at how we can actually help these individuals. And so we started looking actually at the genetic links between, the blast exposures and head traumas and how we can help them. So let's get to the next slide. So right here, you're actually seeing, this is one of my military individuals right now actually using the EVOX system. I'm in brainwave training mode. And I think there was a video. Yeah, there you go. You can actually see what's actually happening here, where he's playing the game and getting his brain to come back on track. This individual was here for right at 2 weeks. He had been through the military for over a year. It's one of the case studies that we're going to talk about, but pretty interesting guy. So we were able to get him a lot of help, and he was able to return to action and do his job. Let's get to the next slide. So I always talk about balance and act, and what we need to talk about is the corpus callosum and the great mediator, right? It's helping the brain balance between the left and the right hemispheres. And this is just a picture of my guys on a chopper. And he's balancing right now. He's hanging on for dear life. Chopper was a little bit overloaded, so wanted to take him up. Let's get to the next slide. So science is catching up to practice. So I thought this is very interesting in that, brainwave synchronization versus age-related decline in working memory. And this was in 2000, this is April 8, 2018. And the American Academy of Neurology coming out talking about the mild cognitive impairment, or the MCI. And if you look at the data on that, that was December 27th of 2017, and then there's print issue of 2018. So I think the word is kind of getting out about QEEG and how we talk about, brain and how it's actually functioning. I just had a very interesting case where a lady was like 77 years old and was diagnosed with cognitive decline. And come to find out, it was a vascular component, because once we put the cap on her, we figured out that her brain was actually pretty well balanced. The husband had an MRI, was showing vascular occlusion on multiple levels. And so once we did therapy on her, and we finally figured out what was going on, the age decline memory issues started going away. So it was more vascular dementia than Lewy body dementia. So that's pretty interesting. Let's get to the next slide. So here's an individual where we did 50 treatments of therapy. This individual had shot over 4,000 mortar rounds into a terroristic country by himself, and was having prefrontal and frontal cortex issues with anger management, started snapping at his wife, started being really mean and ugly to his kids. And we were able to figure out, after a year of going through the military system, traditional workups, he finally got to the office, and we were able to actually show that this individual's brain was back to normal on post-treatment, and also his vision tracking issues had improved, his balance had improved, and so his neurocognitive has improved. So I think it was pretty interesting to show that we were able to get that done and right at about 25 days, right at 3 weeks, so a little over 3 weeks. So pretty interesting time. So what we're looking at here is we actually did some pretrial studies where we were looking at room air and the brain, and then we're actually looking at hyperbaric oxygen at 1.3 ATA and then 1.5, and we were able to actually show that there was an increase in delta wave activity based upon using the hyperbarics and monitoring while they were in the hyperbaric oxygen tank. So it was really cool to find out that we can actually find out an optimal therapy session to get more blood and oxygen to the brain and reducing inflammation, neural inflammation at the same time. So we're able to use this, and we're able to show that delta wave is a type of high amplitude brain wave using humans. Delta wave has a frequency from 1 to 4 hertz, and measured using the electrodes. Right? Yeah, the period of time during the delta waves occurs is often known as deep sleep. But here we're finding out that we're able to actually introduce this in the hyperbaric tank using the atmospheric pressures. And oftentimes, even though people may not sleep, they say they feel really rested after we use hyperbaric oxygen therapy on them. And that's because we're able to optimize their brain waves and show where they're really getting that stimulation. Let's get to the next slide. So we talk about the nightlife. These individuals have to be able to have all sensory functions at night. And a lot of times, we walk through this world living in daylight, and they walk through the world through the visions of the night vision goggles, which, if you've ever put any of these things on, totally changes the depth of perception. It changes how you see, it changes how you work. And oftentimes they're just sleep deprived. They don't really get restful stages of sleep. So we have to figure out how we can best help these individuals, being that they're serving and protecting our country. So let's get to the next slide. So here's an actual video of the delta waves while an individual is actually in the tank. What you're seeing on the left-hand side of the slide of the brain there is that red, that's actually delta wave that we're just tracking. You can actually see the brain calming down on the right, which was very intriguing, because this was the first time it was actually captured while somebody was in the hyperbarics, at the same time knowing which pressure we needed to put this individual on. So we were getting the best resolve effectively for this. So there we go. All right, so this is where the research is catching up with clinical. Here we go. Head injuries can alter hundreds of genes that lead to serious brain injuries. And I remember how I was telling you that UCLA report was coming out. And I just thought that was so neat that somebody could finally put together the science, because as I tell people, I'm just a clinician. I just report and tell what I see in my patients and what they're reporting to me, and then what their outcomes are. And so for UCLA to come out with this in 2017, I thought it was very interesting. And again, that same study is that we're talking about brainwave synchronization, reversing age-related decline in working memory, and how this kind of all ties together. So if you're dealing with people who are on the cognitive decline, really look at their epigenetics and their polymorphisms to find out if they've had maybe previous head traumas or if they've had a family history of events that might have occurred to cause this issue. So let's get to the next one. So oftentimes in practice, I get a lot of epileptic seizure activity after head trauma. But the problem is that EEG in a clinical neuroscience setting does not register in EEG monitoring from 72 hours to a week to 2 weeks. But yet nobody's talking about the superior temporal lobe issue in how the brain's actually functioning. And this is where we're finding out that epileptic seizures can probably not be predicted by changes in brainwave patterns that were previously assumed, right? So a lot of my individuals that come in with epileptic seizure type activity often we're able to pinpoint the superior temporal lobe as a dysfunction area, which then will lead to sensory and motor integration issues for them. So let's get to the next slide. So here's the fun part of the event. We're going to talk about some case studies. So here we go. Case one is a tier 1 military individual, shot over 4,000 rounds of mortars into Syria. You saw some of the stuff earlier. Having headaches, frontal lobe issues, anger management, as I stated before, had been through the entire military protocol for TBI concussions, was still not having any relief at all. Let's get to the next one. So as you can see his balance was off. He was not able to stand up on his left leg at all, which is the non-dominant side. If you actually look at these boxes underneath, on the third one, the tandem firm, which is where his feet were in front of each other, he fell off at 2.7 seconds and 1.5 seconds on the single leg foam. You could see that he's got that frontal lobe at that 2 hertz and 3 hertz function going on, and then some slowing down of the brain. But as and this is why they were having trouble diagnosing him, was that he looked normal, quote unquote, looked normal, but clearly his markers were off in how he was actually functioning. So let's get to the next one. So as we come back now, he's able to statically stand and pass these same exact tests. And now he's reporting that his memory is improved. And as you can see, the frontal lobe, the 2, 3 hertz, 4 hertz is actually improved substantially. His metrics are moving in the way that he needs to move. And now he's in sympathetic dominance, right? So what we're finding out is that most of these individuals in tier 1 providers, which are your elite special operations guys, live kind of in a sympathetic. So you have to understand that they are a little bit different. They're never really balanced in the sense that their brain, it's just not a typical case. You have to understand who you're dealing with. Although his theta beta ratio, we were able to get down substantially eventually for him, and we're able to track this guy throughout the entire way. So it's a pretty interesting case that we were able to help out. Let's get to the next one. So this guy was a 34-year-old NFL player with multiple concussions and checked out by multiple NFL doctors, not once given a QEEG, having eye tracking issues and panic attacks. So this individual was telling me that, hey Kelly, when I'm driving my car and I'm looking at a street sign on the interstate to the right and pulling my eyes center, this is where I spin out of control and I'm having these panic attacks and I can't figure out what's going on. Unfortunately, the SWAT team had showed up twice at his house for domestic abuse, and I've known this guy since 2005. This was my original draft class. This guy was never that way. He loved his kids. He loved his family. He was having suicidal tendencies. And he had taken a Lords of London policy, major insurance policy, and we were able to win the case basically by EVOX and the exam that we've done for him. So he was able to get his case settled. But let's go through his case real quick. Next slide. So we're actually seeing that this guy was struggling, like he was having tons of issues. His brain was slowing down, and this guy was an individual who graduated top of his class. He was an honor student. In college, never had brain malfunction. Clearly, you can see that his brain was lit up on the picture on the left. And then as we move and we get therapy done on him, because he was actually panicking on the second test because he was having a panic attack because he thought that it wouldn't show that his brain was actually better. And we were able to prove that, yes, your brain's better, your balance and your vision have come back, and look at what your family life has become. He's becoming more settled, and his life is now back on track. So, which is what we're always really after, is trying to get somebody's life to be normal again. Let's go ahead and get to the next slide. All right, so I left you with about 15 minutes of questions and answers. We'd love to take them. So if you have them, please fire away.
Yeah, thank you so much, Dr. Ryder, for going through those slides. I think it's so interesting to hear about all the different types of therapies that you really have at your practice and are using. We did have a question come in about neurofeedback and kind of how long you typically find you need to do neurofeedback therapy before results really start to manifest. And after that, how long are these results lasting? I feel like when we hear about neurofeedback, it's kind of, marketed in the way that, oh, it's, changing how the brain actually works and functions. And it's not like a pharmaceutical prescription where if you stop taking it, the results are going to reverse. So what's your take on that?
Yeah, so what I see, depending upon individual, right? So every case is individualized, is what I always have to tell any provider. Typically what I see, I have highly motivated individuals, right? So my job is a little less complicated in the sense that individuals want to get back to their job and want to do it. So their motivation is a little higher, like I'm saying. And then, so I typically see 10 to 12 to 15 sessions in, they're telling me, hey, I'm good. And then we're able to retest them to find out, are they really good or not? And then if they are really good, well, then let's see how you function in real life, right? So let's get back to your job. Let's see if you start jogging your brain. Let's see if you can read a book. Let's see if you can understand these types of simple tasks that you can do now that your brain is quote unquote firing correctly. And then there's individuals that do take longer. Females do tend to take a little longer. So you'll see that 25 to 30 session QEEG thing going on, right? And we don't know quite why that is yet. We can tell you that there's ultimately we thinking about the menstrual cycle and blood loss and dehydration factors once a month that come around. But yeah, females typically take a little longer than normal. The session time wise goes, I always start off on a very conservative 15 to 20 minutes of training just to see how they respond, because my goal is to never make that patient worse than when they came in that day, right? So if they're scheduled up for neurofeedback and they're not feeling great, then we're going to go to some other therapy, because I don't want to stress the system out any more than it already is, right? So this is where we use laser therapy to calm the brain down. This is where we use hyperbaric oxygen therapy, bring the brain back around. And then the following day, they may be, or the next 2 days, they may be ready to go in for another neurofeedback session where they're feeling great and we're able to get success faster. So we take a little different approach to just that standard, every other day somebody comes in for neurofeedback or whatever their schedule may be. So that's how we approach it.
Yeah, that's a really interesting approach. And a related question is there kind of a broad TBI neurofeedback protocol that is used, or are you really basing it off of the individual, their motivation level, seeing how they respond to that first training session and kind of going from there?
Yeah, everybody's independently done. I do not put anybody into a box of just TBI, concussions, and let's go, right? Because everybody's going to complain of different situations and different signs and symptoms. So I really address everybody on an individual approach. and check out individuals based upon how they're responding to that 20 minutes. You know, if they tell me they're a little bit fatigued and their brain's functioning better, okay, well, that's fine. I can deal with fatigue. But as long as I'm not causing signs or symptoms where they're, you know, they're having massive headaches, they're having sensitivity to light or whatever it may be, sounds, they're having trouble driving or riding in a car. Yeah, we don't, I don't want to push somebody past that point where they're starting to struggle. So
absolutely, that makes sense. And in terms of monitoring their response to therapies, whether it's neurofeedback or hyperbaric oxygen, what have you, are you typically relying on the patient's self-report of, oh, I'm feeling like I am sensitive to light, or are you doing these QEEG assessments kind of on a regular basis throughout your therapy protocol?
So what I do is I'll do the signs and symptom sheets of the 23 signs and symptoms of post-concussion scored scale. And then I'll put them on the balance examination too, because if that balance is coming back, I can tell that their brain is actually functioning. But I'm also using the EVOX system to tell me how is that brain actually recovering, right? Because I need to be able to monitor in these courtroom cases, so motor vehicle accidents to NFL guys to blast injuries, whoever it may be, I need to be able to back up substantially with evidence to show that this individual is making that progress. So therefore, if and when that courtroom, you know, I get that call to go to that courtroom, I'm able to explain why this individual only did 10 sessions or why this individual may have to do 35 sessions, right? So I take a very unique approach to monitoring concussions. I use the eye tracking V&G goggle system where it has, you know, binocular, meaning both eyes are being tracked and traced in speeds. I use, you know, your guys' system and other systems also in monitoring the brainwave activities, and then checking out balance, right? So therefore I can know that if the brain is actually starting to come back on in a very cost-effective manner for the patients. So.
Great. Now, a little bit of change of subject. We had a question of basically if you can just elaborate on delta wave activity and how it is so pertinent for this type of a patient population. Included in that question was, do you refer out to do EEG sleep studies? Is that helpful, or are you really just deriving this kind of sleep behaviors, if they're getting restorative sleep, off of the delta wave activity you would see in something like an EVOX assessment?
Yeah, so I use primarily the EVOX system for telling me that. Delta wave is super important because you have to remember a lot of these tier 1 military providers, they don't have what we would call normal sleep. They're not the typical human being getting 7 to 8 hours of sleep, or they're up at all hours of the night. They're really night shift worker syndrome that they really have. So delta wave becomes important to me because I understand that with restorative sleep, the brain then restores and rebuilds and tries to recover itself. I mean, we are a self-righting mechanism. We try to get to homeostasis as soon as possible and as often as possible. So for me, delta wave became very important in tracking in my NFL guys and my military population because of their reported sleep issues and their sleep problems. But yet when they go and get sleep studies done, they're finding out that they're quote unquote sleeping and getting the required hours of sleep, but yet they're never getting into REM sleep, which is important because that's where the brain actually regenerates and recovers itself. So yes, sleep studies are important if that's where you think an individual may need to go. In my case, a lot of my cases, they bring that study with them to the office on the evaluation, and I go, so what they tell you? And they go, well, they say it's normal, right? And there's no issues. So there we go, right? And even if they're having sleep apnea, a lot of times once the concussion has occurred, we put them in the hyperbarics, and that once that vagus nerve is stimulated the way it needs to, the phrenic nerve and the vagus nerve, the lungs and the diaphragm actually start to kick back up. We're talking about that autonomic nervous system again, and everything turns back on, and then that system is back up and running again, right? So it's pretty interesting take on what actually happens in that true delta wave activation. So.
Yeah, very interesting. And now we've got a question about the use of SPECT scans or diffusion tensor imaging and kind of their possible application for TBI cases. Do you have an opinion on that?
SPECT scans are used by multiple individuals that are out there, and I think SPECT scans are cool, very costly, and I don't like the exposure to the dyes that they have to put into to these individuals. So a lot of it, SPECT scans are used with hyperbaric oxygen for the fact of perfusion to show oxygen and blood flow to the brain, which we know that when you put somebody into a hyperbaric oxygen chamber, you're gonna increase blood flow, you're gonna increase oxygen. So I personally prefer using QEEG and brain mapping to find out what the brain's actually doing, because we know structurally there's nothing wrong, right? I can honestly say up to 99% of the time they bring in CT scans and MRIs that show that there's structurally nothing wrong with the brain. There's no bleeding, there's nothing, no damage to it. But other than that, they're complaining of these signs and symptoms. So the only way that we can really get that down is by using a system like EVOX to find out how's the brain functioning. You know, I always tell people it's like bringing your car to the mechanic and you know, you say, hey, I'm having trouble, and then they plug in this little computer into your computer of your car, and then it tells them that these sensors are off, or this part of your car is not working correctly. And using QEEG is kind of like that, where SPECT scans are just saying, yeah, your car's not, SPECT scans like saying your car's not running right. We hear something funny with it. But then using the QEEG is like an application of sticking that computer into the car and finding out actually what is going on with it. So SPECT scans kind of give you a global view, and I like using the QEEG because it pinpoints things. So we're able to really get these individuals kind of pinpoint precision therapy and treatment. So
yeah, that makes sense, and you know the price point doesn't hurt either.
Well, I think the rate right now is right at $4,000 for a SPECT scan. That's a great sum.
Okay, I think our last question of the day is about motor vehicle accidents. Have you treated a lot of patients that, you know, aren't your elite military members, aren't your NFL athletes, but just are kind of your everyday person that had a car accident? And do you find that the pattern of dysfunction in the brain displays similarly to those more elite performance cases, or is it different?
No, it's actually the same. And what's pretty interesting is that there's, you know, there's so many reported cases of these individuals stating that they're having all these signs and symptoms in the ER and after motor vehicle accidents, mainly in T-bones. T-bone accidents where an individual gets a lot of shearing or rotation of the head and they get the counter coup is some pretty interesting cases where they're reporting these signs and symptoms, but they're never checked out in the ER, right? So there's not like an on-site neurologist to actually do the signs and symptoms and really evaluate these individuals. So yeah, the brain doesn't change just because you're an elite individual or you're an NFL guy or whatever it may be. The brain still functions the same. They're just higher performing individuals, right? So they have a little different, as I like to say, they have a little different job than the typical individual, but for the most part, the brain still functions the way the brain functions. So you know, we've had a lot of success in presenting this information in motor vehicle accidents where we're actually able to prove where the injury, the coup and the counter coup injury actually occurred. So where the MRI and the CT scans and the SPECT scans cannot do that. So fun times.
Right, great. Okay, well, that wraps up our Q&A session. And just a quick reminder that if you have any questions about today's Lunch and Learn, if you're working on a challenging patient case, or if you want access to more of these clinical education materials, including that in-depth discussion of TBI electrophysiology biomarkers, just email medicalaffairs@evokeneuroscience.com. I'm happy to get you the resources you need. Thank you so much, Dr. Ryder, for joining us today. That was very interesting to hear about your experiences with treating these elite athletes and military personnel. Absolutely fascinating, and such a wonderful opportunity to hear about really the personalized approaches that you're using to not only get to that correct diagnosis, but to treat these individuals and get them back to good cognitive functioning. So thank you again for joining us, Dr. Ryder, and thank you all for attending our webinar. Have a great day, everyone.
Thank you.